Good evening, and thank you to all of you who have joined us this evening for this Daily Maverick live webinar to discuss where we are with the COVID-19 epidemic in South Africa, to look at our response, to look at what has happened and what can be done better as we go forward. It's the 10th of May. We are on day 45 of the lockdown. Internationally, I just checked the WHO website. We are ticking very, very close to 4 million confirmed COVID-19 cases. And in South Africa, although we don't have the latest figures for today, yesterday at this time, there were 9,420 confirmed cases and 186 deaths. Tragic deaths. So we're in the midst of a serious epidemic, and a number of people say that we are about to go into a phase where we will see exponential increases. But as I said, it's almost 2 months since the start of the national state of disaster. There's another month before President Ramaphosa has to renew the state of disaster. So that makes it a good time to take stock of what we have done and what we need to be doing. And for that purpose, we are joined this evening by Professor Shabir Madhi to help us understand the issues that are at stake. Professor Mahdi is about as world-class as you can get when it comes to scientists. He has 450 co-authored what scientists call peer-reviewed articles. He's a vaccinologist. I didn't know there was such a thing until a few days ago. He's an infectious disease specialist, and he's a leader in Africa in the science of disease and of infectious diseases. But we wanted Professor Mahdi not just because he is a clever chap, but also because he's been on the front lines, together with many other scientists and many other healthcare workers, of trying to make sure that we save every life possible. But I also wanted Professor Mahdi to join us because he is one of the scientists who has been questioning of aspects of the response. And I think particularly in the last couple of weeks, we've begun to hear more of Professor Mahdi's criticism or questions, questions that also come from his position as one of the group of our scientists who is an advisor to the Minister of Health. So Professor Mahdi, good evening. Thank you for taking your time on a Sunday evening. I want to chat to you about what's working, what's perhaps not working, and what you think should change. And I want to talk through a number of issues: the lockdown, the testing strategy. You've been raising questions about schools, about how we are modeling this epidemic. But let's just start with the lockdown. As I said, we're now nearly 5 weeks into the lockdown. Can you just say what you think has worked? Let's start with that. What do you think we've achieved so far by the lockdown?
So good evening, Mark, and thanks for having me. So Mark, perhaps let's just take a step back and just try to understand why we actually embarked on the lockdown. So South Africa really embarked on the lockdown at a relatively early stage of the epidemic compared to many other countries at that point in time that were embarking on the lockdown really during the midst of when it was beyond their control and capacity to basically prevent community transmission. So we really are very different from the European countries, from what was happening in the US, from the UK, in terms of the reasons why they embarked on a lockdown. So what were the reasons South Africa embarked on lockdown? The main reasons would have been probably threefold. The first reason would be to try to interrupt the rate of community transmission. Now, I think it's important to appreciate that when we're talking of interrupting the rate of community transmission, that is not the same as eliminating the virus. Unfortunately, part of the messaging...
Just to interrupt you for a second, community transmission means those infections that are taking place from person to person within South Africa rather than imported from outside the country, correct?
Exactly, that's exactly correct. So the imported cases are obviously what lends itself to the seeding of the virus in the country. And then once the imported cases start sort of infecting other individuals, and those individuals go on to infect other individuals in the community, that's what we would refer to as community transmission. So that was the first sort of objective, to reduce the rate of community transmission. But again, I need to emphasize, it's not about eliminating the virus. In the whole history of mankind, we've only been successful ever with eradicating one virus, and that is smallpox. And the reason we accomplished that was because of vaccination. Right? There's no other virus, and especially no respiratory virus, that we've ever been successful in terms of eliminating completely. So that was the first reason. The second reason why a lockdown was probably required in South Africa really referred to the state of readiness of our healthcare facilities. And it's not unique to South Africa. What we see happening in Europe, what we see happening in Spain, in Italy, in the United Kingdom, right? And the United Kingdom is probably as far as you can go in terms of aspiring to have a national health insurance type of a system. The reality is that none of these countries were equipped to deal with the surge of cases that occurred. Okay, so it provides us an opportunity for our healthcare facilities to better equip themselves, right? And it probably required much more time for our healthcare facilities to equip themselves to deal with what is going to be an inevitable issue, and that is there is going to be a surge of cases. Now, the third reason, and probably the most important reason, why we needed to embark on the lockdown, right? And this is what the WHO says, and it wasn't what I say, right? The WHO insists that when a country embarks on a lockdown will not eliminate the virus, right? What eliminates the virus is the ability of the country to test at scale, right? To chase after every infectious case as far as they can go, to get those cases, to put them into isolation. After that, you need to trace down those contacts of those cases. Those contacts need to be first investigated to make sure that they're not infected. And if they're not infected, then they need to put into quarantine. Right? So you're basically removing the infectious cases as well as the potential sources of future infectious cases from as far as you can go. Right? But now there's certain dimensions that has emerged over the past 2-3 weeks. And that is the recognition that between 50 to 80% of people that are infected with this virus are asymptomatic. Okay, and we'll come back to that later. But let's visit the issue of the scaling up of testing during the period of the lockdown. So why is it different to do it during a lockdown compared to sort of less where people are still allowed to mingle? The reality is that during a lockdown, what you're able to do much more efficiently is trace the contacts of individuals that are infected. Right? Just before the lockdown in South Africa, we were tracing less than 20% of the contacts of individuals that were identified to be infected. The modeling data shows that for you to be able to curtail the transmission of the virus at an early stage, what you need to do is you need to be successful in tracing 80%, at least 80% of the contacts. If you're not able to trace 80% of the contacts, you're going to get onward community transmission. You're not going to be able to contain the epidemic for all intents and purposes. So there might have been an opportunity for containment of the epidemic, but very unlikely, because by the time we started to the lockdown, there was already community transmission. So how well did we do in those three regards? In terms of...
But you said a second ago that we started early as compared to other countries.
Transmission, by virtue of having been in a lockdown, by virtue of people not intermediate. Sorry, Mark, you broke up there?
Sorry, I interrupted you, but I just wanted to clarify one thing, because you suggested that South Africa started relatively early compared to other countries, but then you've just said that we started late because community transmission was already underway.
Exactly. So that's what I was going to say.
Elaborate.
Yeah. So there was a belief that we could actually interrupt transmission through a lockdown, and we cannot interrupt transmission through a lockdown once there is community transmission. But unfortunately, there was a perception, and that perception might exist even today, that we're going to be successful in terms of interrupting community transmission. It's not about interrupting community transmission, right? Each year we have influenza virus. Each year we have a number of other viruses that come and go, right? And there's no interrupting those viruses. What you can do, right, is you can try to reduce the rate of transmission, right? And the same number of infections are likely going to take place, but over a longer period of time, right? So yes, we did reduce community transmission. We certainly didn't eliminate community transmission, right? So there was some reduction. The exact magnitude of that is difficult to quantify. And the reason why it's difficult to quantify is that, in fact, in the first 2 weeks of the lockdown, rather than increasing the number of tests that were being done, the number of tests actually decreased compared to just before the lockdown, right? So we were doing less than 1,000 tests across the country in the first 2 weeks of the lockdown. Just before the lockdown, I think that figure was sitting at about 2,500, 3,000. And that's the reason why just before the lockdown, we were seeing a doubling rate of about 3 to 4 days in terms of the number of cases. As soon as the lockdown was implemented, what we saw was a drop in terms of the number of cases, right? And that's a function of two things. The immediate drop that we saw in the first few days of the lockdown is not because of the lockdown, because those cases that are manifesting in the first 2 days of the lockdown, right, are cases that were probably in an incubation period just before the lockdown, and now they're becoming clinically symptomatic in the early phase of the lockdown. So the drop in cases immediately after the lockdown is more a reflection in terms of us doing less tests than we should have been doing. So that's the first issue. Now, as we started to scale up testing, and over the past 2 to 3 weeks, just the 2 to 3 weeks before the lockdown actually ended, the total lockdown ended, what we saw was a tenfold increase, close to a tenfold increase in terms of the number of tests that were being done. So right at the tail end of the lockdown, there were roughly about 400 new cases being diagnosed, as compared to about 40 new cases that were being diagnosed in the first 2 weeks of the lockdown per day, right? But the only difference between those two, really, is that there's tenfold more testing taking place towards the tail end of the lockdown. So if you test more, you're going to find more cases.
Okay, so let me pause you there just for a second, because you're galloping, and I want the listeners to stay with us. So I'm taking two things out of this. Is that critical to the lockdown was creating space and opportunity for testing in order to track cases, in order to isolate, because by isolating, you prevent onward transmission. You don't eliminate, but you contain the size of the epidemic. That's key one. That is a raison d'etre, if you like, a whole purpose of doing the lockdown. You are saying that certainly for the first 2 weeks, we weren't ready to do the testing part, if I understand you. Now the testing has scaled up tenfold, as you say. And yesterday, I think there were 523 new registered cases. But we still have to take the same approach. Each person has to be who tests positive has to provide all of their contacts. We have to trace those contacts. We have to test. We have to isolate or quarantine. So it's an order of magnitude greater. I mean, perhaps there's two questions here from people watching. One is that I've heard that on average, every positive person may have up to 20 people who need to be traced. So if you have 400 people, that means that 400 positive cases a day, you have to trace 5,200 people. But secondly, how quickly do you have to trace? And how quickly are we getting turnaround on the tests?
Right. So, Mark, the first thing is that, in fact, it's not every person having 20 close contacts. Maybe during the lockdown, it might be 5 to 10 close contacts. On average person, as an example, someone is taking public transport, a taxi, right? A close contact is defined as someone that you're in contact within about the 1.5 to 2 meter radius for at least 15 to 30 minutes. Now, if someone is commuting in a taxi, right, that person is already in close contact, right, with about 7 to 8 people just in that one trip in a taxi. And he then takes another taxi to another place, and that's another 7 to 8 person. In high-income countries, the average person actually has 17 close contacts per day, not per person, per day. Right. Now, a person is infectious from about 3 days before they become symptomatic up until the time point when they're actually identified and beyond. But in terms of the contact tracing, you need to be doing contact tracing of everyone that they've been in contact with from 3 days before they became symptomatic up until the time point when they actually go into isolation. Right. And say, for instance, say that you actually tested on day 2, and we'll come to the issue of the duration of when the results needs to be turned around. But say you tested on day 2 and you get your results within 24 hours. So that individual has actually got 6 days that they were infectious. And in fact, they're most infectious during that period of time, the pre-symptomatic phase and the first few days of being symptomatic. So you would roughly need to trace down closer to 120 close contacts per individual that's infected. And you need to do that for at least 80% of this context. South Korea were able to do it for 95% of the context, and not just by way of using sort of cell phone usage parametrics, but actually tracking down, using that as a platform to identify the context, and then going out to actually physically engage with this context. So it's a huge equation. Now, if you're talking of 500 new cases, that is 500 times 120, right? Assuming that you're basically getting your results back within a 24-hour period. So what is happening right now? So we still at the first reason of the lockdown, and that was this whole issue of trying to reduce the rate of transmission. The reality of what is happening right now, right, is that it's taking anything between 5 and 14 days for a result to come back after the person has been sampled, 5 to 14 days. Okay, for all intents and purposes, someone that gets a result back after 7 days and they haven't been symptomatic for 2 days, that person is, in terms of his infectiousness, sort of wanes dramatically. That person is much less infectious than a person that is symptomatic at day 2. So if we can't get a result back within 12 to 24 hours when it comes to community screening, right, for all intents and purposes, those tests are meaningless. They add very little value. When we report on the number of tests that are being done, the more important metric is how many of those test results have come back within 24 hours. We're talking now of community transmission and testing in the context of community transmission. The important metric is how many tests were done, how many of those results came back within 24 hours, how many contacts were identified for that individual, and what percentage of those contacts were actually traced, tested, and if they test positive, they need to go into isolation, and then it goes, or you need to do all of the same for their contacts. But if they test negative, they need to go into quarantine for at least 14 days. Right, so this is a mammoth task. This is something that works at the start of the epidemic when there's few cases. Right, you reach a critical tipping point when it becomes impractical, implausible to be able to achieve that sort of success.
Now, before you go to that tipping point, because I think you're going to tell us in a minute that we're getting to that tipping point and that we have to rethink our testing strategy. But again, I just want to take you back a little bit. We are not South Korea. We don't have South Korea's health system. We're not industrialized. We're a developing country. We know that we have a weak healthcare system. You described it as a mammoth task that would have faced us under any circumstances. And by your account as a vaccinologist, we locked down, but we didn't use the lockdown effectively for its main purpose, which was to test, track, isolate, quarantine, interrupt. But you're being critical, Professor Madhi. What should we have done? Are you saying we shouldn't have locked down at all? Some people might say, yeah, but Mahdi is just asking the impossible. We had to do something, and we did something decisive. What would you have said people should have done? I mean, I've heard scientists, Professor Abdul Karim, saying, the lockdown allowed us to flatten the curve. It allowed us to carve out a unique trajectory for our epidemic. Answer those questions, and answer them a little bit less technically, if you don't mind.
Okay, so am I saying that you shouldn't have embarked on the lockdown? And the answer to that is no, that's not what I'm saying. But I'm saying that the timing of the lockdown in relation to what should be the main purpose of the lockdown, and that is to be able to control the rate of transmission, was not correct, right? And that's what I'm saying. So had with our testing capacity being intact, and we had the right criteria in terms of who should be tested, we would have been more successful in terms of identifying individuals that were infectious, right, that were lending themselves to community transmission, right? And we would have you can't avoid it, right? But the rebound that you're going to experience once you start phasing out the lockdown could have been less. But there's no second guessing whether it would have been or would not have been. So I'm not saying the lockdown was the wrong decision. The main reason the lockdown was probably important in our context, right, was actually because our healthcare facilities were not actually prepared. What the lockdown has achieved is that it has bought us time. What the lockdown has not done, and what no future intervention is going to do, and we need to be clear about this, right, is that it's not going to reduce the number of people that are going to be infected in South Africa. be it over a 6-month period, be it over 2 months, 2-year period. And in all likelihood, this pandemic is going to be with us at least through to the end of 2021, if not 2022. And that's what all of the modeling data shows, right? That as with past pandemics, you do not get sufficient number of individuals in the population that become immune, which basically is what you require for there to be interruption in terms of the rate of transmission of the virus. Okay, so our healthcare facilities were simply not prepared. And that has brought the healthcare facilities time to better equip themselves on multiple levels, in terms of the number of beds that are available, in terms of the number of oxygen points that are available, in terms of procuring protective equipment for the healthcare workers, right? And just in terms of the structuring of the healthcare facilities. So that part we can tick. Well, we can sort of tick it. We're not too sure exactly what is going to come our way, right? But as far as you can achieve within a 3 to 5 week period, right? You do not build healthcare systems over a 3 to 5 week period in no country in the world, right? But you need to be able to do something. So that is probably better equipped our healthcare facilities in terms of dealing with a third surge of cases that is imminent. And there's no getting away from it. And there's no way going back to a lockdown is going to in any way mitigate what is going to be a surge in a number of cases, because it's not sustainable from multiple levels, including the harm that it's doing.
So stop there for a second. We can't go back to a lockdown, you say. A surge of cases is coming. It's unavoidable. So what is your advice to government at this particular moment in time, if not lockdown? What will help us now?
Yeah. Well, the only thing that's going to help us is for the citizens of South Africa to take responsibility. It's for the citizens of South Africa to take responsibility in terms of reducing the rate of transmission. Government can come with every policy in the world. If it's not the citizens that are buying into that particular policy, into those sort of recommendations, we are going to fail as a country, right? And what I'm talking about are the non-therapeutic interventions that have been propagated, that have been recommended over and over again. Things such as social distancing, avoiding overcrowding, things such as using a non-surgical face mask in the general population, things such as hand hygiene. Those are interventions that are going to assist us in terms of reducing the rate of transmission. It's not going to protect people completely from becoming infected. A non-surgical face mask, right, does not protect someone from getting infected. It prevents that person from transmitting the virus. And it is that package which is going to assist us in terms of reducing the rate of transmission, right? So if government proposes that, whether it's a level 4, level 3, or level 2, if people are not still abiding to those sort of recommendations, we are going to fail. We're going to have an acceleration in terms of community transmission. Now, for that to happen, you cannot be coercive, right? There's a whole lot of things that are of concern right now. The notion that you can force people into isolation if they test positive. This is the reason why, as an example, in Soweto, roughly 30% of people that are being screened at a household level that are symptomatic are refusing to be tested, right? They're refusing to be tested because of a threat, right, that they will be put into isolation, right? So these are issues that we need to take. Well, in terms of that's a fact. In terms of the screening that we're doing, that's exactly the experience that we're coming across. People are concerned to be tested, right, because they're afraid that they're going to be forced into isolation. So it's approach. Now, the biggest thing that we need to do, right, we need to demystify this illness. Right, we need to demystify it. What am I talking about? The way COVID-19 has been projected, in a sense, is very much from a high-income country perspective. Okay, why am I saying that? Right now, the country with the highest mortality rate in the world is Italy. Right, the mortality rate from COVID-19 is 500 per million of the population. In the United States, the mortality rate from COVID-19 is roughly about 230 per million of the population. Okay. Now, what is the mortality rate from tuberculosis in South Africa? If you go by the WHO estimates, the mortality rate for tuberculosis in South Africa is close on to 800 per million of the population. 800 per million of the population. In terms of what the Actuarial Sciences Society estimated for South Africa, that there would likely be 48,000 deaths from COVID-19 in South Africa. What is it? Those deaths are firstly not going to occur, unlikely to occur in a single wave of the epidemic. We're going to have multiple waves of this epidemic. But what does the 48,000 deaths actually translate into in terms of mortality rates? That 48,000 deaths translates into roughly less than the number of TB deaths that are actually going to occur in South Africa. Okay, WHO estimates that the 60,000 TB deaths that are going to occur in South Africa, there's 48,000 COVID deaths that might occur in South Africa over a period of 2 years. So even if all 48,000 deaths occurred this year alone, right, that roughly translates into about 600 to 650 per million of the population. Now, what's happening right now? So let me just unpack that a bit further. So how much can we do to actually prevent this COVID deaths? And I think that's another really important aspect. There's a belief that we can prevent the majority of this COVID deaths, and that's a false belief. And the reason why it's a false belief is that when there's a certain group of individuals over the age of 65, over the age of 70, individuals with comorbidities, when they develop this illness, they go along a certain trajectory, which unfortunately is not reversible, including putting them into an ICU. In the United Kingdom and the United States, the percentage the survival from an ICU of someone that's ventilated is roughly 10 to 20%. Like 90% mortality rate of people that are admitted to the ICU in the United States, 70% mortality rate of people that are admitted to an ICU in the United Kingdom. In China, exactly the same thing, 70% mortality rate. So it's unfortunate, right? But the reality is that, like with every other disease, there is a loss of life, right? But what's happening, right? Not just in South Africa. What's happening throughout Africa is that the response to COVID-19 is effectively setting up us, right, for greater mortality and morbidity from non-COVID illness than directly from COVID. There's been a 50% reduction in terms of the number of tests that were done for TB in South Africa during the lockdown period. And that is not because the lockdown has gotten rid of TB. Right? These are delayed diagnoses. And if you delay diagnosis, you got a poorer outcome.
So you're throwing a lot of things at us at the same time. And it's all very important. I have to backtrack a little bit because I also want to leave people with some practical sense of what they must do, what government must do, etc. But I think one of the things that you've said is that our epidemic is not on a unique trajectory to South Africa. Our epidemic it reflects the socio-economic circumstances of South Africa, as an epidemic in another country will reflect that country's socio-economic environment and its health environment. But can you explain to people why, even given what you've said about the inadequacy of testing, why are we seeing higher rates of positive cases, for example, in the Western Cape than anywhere else? Is there something special going on in the Western Cape that we need to be worried about? Can you just take that chunk just quickly?
Right. So I think there's obviously, like everything, there's a number of reasons at play. But one of the reasons is that the Western Cape is testing a greater percentage of the population than other places. So if I'm not mistaken, roughly about 25% of all of the testing that's being done is being done in the Western Cape. And that's the reason why the laboratories in the Western Cape right now are completely under pressure, and they're only able to turn around the result in the huge volume of tests that is being done. In addition to which, the Western Cape seems to have been taking a different approach from many other parts of the country, in that they're targeting what they consider to be sort of high-risk areas and what they sort of are mapping out as being hotspots. So they're going to specific areas much more than just the general population. So they're basically picking up more cases because they're much more targeted, much more focused in terms of who they're testing, and it might be the criteria that they're using for testing also differs. Furthermore, there's also been a few instances of outbreaks within a factory facility, within certain facilities in the Western Cape, which are sort of lending itself to an increase in terms of numbers, right? And I think that's what's really driving the Western Cape. But in addition to that, if we go with influenza or RSV, which is another virus, respiratory syncytial virus, those are seasonal viruses. And not strangely enough, the experience with those viruses is that they're more likely to start off in the Western Cape, in South Africa, before it goes up north to Gauteng. Right? So there might be some climatic factors at play as well. So I think it's a combination. There's no one single answer. There's a combination of factors that are contributing to that.
Okay, I think that's that, and we'll see things developing in different ways in different parts of our country as we go along. Again, going back a little bit to something you said a few minutes ago, a number of people, and I wondered myself as I listened to you, you said citizens must take responsibility. The alternative to a lockdown is that citizens must take responsibility. And I thought, isn't that a bit naive? You think citizens are going to take responsibility? And the few people who've listening have said that, well, if that's the response, then it's nothing. What do you mean? And what should government be doing or business be doing in that case to help citizens to take responsibility?
Yeah. So it's all about messaging. And let's just take a real life experience. Okay, the Nordic countries. Sweden has taken a completely different path compared to the rest of the Nordic countries. Sweden did not impose a lockdown. The rest of the Nordic countries did. Okay, Sweden said we trust our citizens to do the right thing, right? Now, Sweden has got a mortality rate that is roughly about twice more than Denmark and about 5 times more than Finland, right? But the mortality rate in Sweden from COVID-19 is roughly about 140 per million of the population, right? Compared to 500 per million of the population in Italy, right? It's much higher than it is in Denmark, but they did that at minimum damage to the economy, right? So they decided on a specific strategic pathway, right? And that was to aim for prevention in terms of trying to reduce community transmission. In the initial phases, in fact, in Sweden, they were a bit too liberal about it. They still allowed mass gatherings of up to 500 people. The restaurants were still functioning, right? When things started to go out of control, they sort of stepped back and then limited mass gatherings to 50 people, right? But the important messaging was the messaging of social distancing. The important messaging was hand hygiene, right? So we're not Sweden, fair enough. Our populace is not the same as in Sweden.
Professor, we're getting that messaging. Everybody knows they must wash their hands. Everybody knows now everybody wears masks. What more?
Well, it's getting the buy-in from citizens. And unfortunately, there isn't any magic bullet. A lockdown is not a magic bullet. Phase 4 is not a magic bullet. Phase 3 is not going to accomplish anything less than a phase 4 if the citizens don't do what they requested to be doing. So it's about being responsible, right? And if we can't do that, unfortunately, what we're setting up ourselves for, irrespective of what policy government has, right? If we're not able to abide by those sort of conditions, if we can't create an environment for people to actually practice those sort of interventions, we're going to have a much quicker rate of transmission of the virus, and we're going to get a surge much sooner, and the peak with this wave probably will be much greater than we expect if those non-pharmaceutical interventions don't work and if we don't buy into it. And there isn't anything the government can do.
So in practical terms, if government did much more to get water into communities, to get sanitizer to clinics, to get PPE to healthcare workers, to test in a focused and appropriate fashion. You've said that we must do away with mass screening now and that our testing strategy must be much more targeted. So if there were a bunch of socio-economic interventions combined with much louder, much more science-based, evidence-based, myth-busting public health information, that would be helping us.
That would help us. And I think you raised another important issue, what type of testing and how can we actually try to get greater community buy-in in terms of these interventions? Do we need an army on the street? The answer is no, right? Do we need police to enforce certain sort of regulations? The answer is yes, right? But we go to another issue in terms of the strategy that we've adopted when it comes to community testing. So we're adopting a strategy which no other country in the world has adopted, and that is doing household visits to screen for symptomatic individuals and then to test those individuals. Now, the reason why no other country in the world has adopted this, right, is quite simple, right? This is a respiratory virus. Doing a household visit today, right, and not finding a symptomatic individual in that household today doesn't mean there isn't going to be someone that develops the symptoms 2 days later. Even though we've got 28,000 field workers that are doing these household visits from the last time I heard, we've got 14.5 million households in South Africa. Each field worker would need to take responsibility for at least 500 households. They're not going to be able to do a visit every 2 to 3 days. So that sort of a strategy in terms of trying to identify infectious cases, unfortunately, is fundamentally flawed. What needs to happen is that there needs to be more access in terms of testing facility in the communities. We can't have 3 testing facilities for the whole of Soweto with a population of 1.3 million, right? What's happening right now is that when someone has a respiratory illness, they go to a clinic. That clinic is not a testing facility. They refer that person to another testing facility, which is 10 kilometers away. That person doesn't even pitch up at the other testing facility. We need, if we are serious about wanting to test and identify infectious cases in the community, that is what we need to do. But we pretty much, that sort of window of opportunity in terms of what we can achieve with that is closing in on us, right? If it hasn't passed us by already. Because like you said, when we identify 500 new cases, how are we going to mobilize the resources, right, to actually trace their contacts? And the projection is in 2 months from now, it's not going to be 500 new cases. It's going to be close to 6,000 new cases per day. And it becomes implausible to basically even put those in isolation, let alone trace their contacts. Right? So we need to reassess the big issue around testing right now is that what we face in South Africa is we need to live up to the reality that despite the NHLS at one stage having indicated that by the end of April, they would be able to do 36,000 tests within a 24-hour period. Right now, with 10,000 tests being done per day, it's taking anything between 5 to 14 days for those test results to come back. Right? So we need to reprioritize what we want to use the testing for. Right? And what we're arguing is that patient care is being compromised. Healthcare workers' lives are being put at risk, right? When we've got a turnaround time of 5 to 14 days. The testing in hospitals needs to be prioritized unconditionally, right? And we need to make the choice. Do we still chase after the extreme unlikelihood that we're going to be able to identify those infectious cases, put them into isolation, trace all of the contacts, right? And that's not even considering that 50 to 80% of infected people are asymptomatic, right? Or do we prioritize testing in healthcare facilities so we can actually get a turnaround time of less than 24 hours? So we can decide how to manage our patients. So our healthcare workers can decide what sort of triaging is required to protect themselves as well.
Okay, so you're making practical suggestions. You know, a friend of mine joked to me that, you know, Shabir Madhi is a lockdown denialist. I don't think you're a lockdown denialist. You may want to comment on that, but what I'm interpreting is that you're saying that the lockdown has been effective in certain respects, but there are other critical strategies now that need to be identified. You're critical of the testing strategy, but you're not saying throw it out of the window. You're saying do it differently. And one of the things you're saying is improve the throughput of the National Health Laboratory Services. Another thing you're saying is put testing closer to people. As in with HIV, we pioneered voluntary counseling and testing, make it possible for people in communities to go for COVID-19 testing and so on. So there's a whole number of practical measures. But what you're saying it's a very different message to government strategy at the moment. You're more critical than I thought of the strategies. You can comment on that very briefly, Shabbir. I want us to move on to schools and education in a second, but I'll give you 2 minutes maximum just to respond to what I've said.
So, Mark, firstly, I'm not a lockdown denialist. I certainly am not. And a lockdown has got a place in an epidemic, but it needs to be driven by a specific objective. And we need to be clear about the objective, and the conditions need to be conducive to actually achieving that objective before you embark on the lockdown, right? And when it comes to testing, I'm not saying throw community testing out of the window. I'm saying at this point in time in an epidemic, right, in terms of the testing that's available in the country, and I'm talking of PCR testing, right, it simply doesn't lend itself to achieving what we're actually setting out to do when it comes to trying to identify infectious cases to reduce the rate of transmission, right? That's what I'm saying. Testing is still needed in the community. And the reason why testing is needed in the community is we need to get a better understanding in terms of how this epidemic is panning out in different communities. But the type of testing that's required then is not to identify infectious cases, it's to identify hotspots. And you can do that with the rapid antibody tests. Right? The rapid antibody test is not going to tell you who's infectious. And it's less susceptible to biases because you can do much more systematic sampling, and you need to do serial sampling to see how the epidemic is evolving. So you can identify different communities where there's heightened transmission, other communities where there's less transmission, and you can have a much more targeted approach in terms of what to do in those particular settings. So testing in the community is still required, but it's not being achieved for its purpose using a PCR test. And now we need to change strategy and go towards what is really prevention and trying to identify which are the hotspots. And that is where the focus needs to be now when it comes to community testing. Asking people to go to the clinics to be tested, unfortunately, that is not going to help us in terms of what's happening in the hospital. And it's not helpful when we can't trace more than 80% of the contacts of those individuals, or when it's taking 5 to 14 days for them to get the result back.
I hear you. I think, Prof, what we should possibly do another time, because it's not easy to do it in a conversation, it would be useful to just have almost a lecture, a Professor Mahdi lecture on COVID-19 testing, the difference between an antibody test, a PCR test, a saliva test. I'm seeing a lot of questions around that, but also how different tests relate to different public health strategies, because they're used for different outcomes. But there just isn't time to go fully into that. I would say to people that it's worth reading an article which is you've just published in The Conversation about the testing strategy, which I think sets out the approach that you are suggesting very convincingly. I should also, somebody picked me up for, it wasn't me who said you're a lockdown denialist. I was just taking it to an extreme, that is what somebody has said. I don't believe that at all. I think that your critique of the lockdown and the way it's evolved is very trenchant and very important and very informed at this moment in time. But let's move on. You've also created a little bit of a stir by what you've said about education and about the fact that you think schools should be planning to reopen. Can you explain a little bit about that? Can you start by explaining, first of all, just, and again, simply as possible, the issue of what's different about COVID-19 in children, as far as we know, and then from there, go to how you think that has bearing on whether or not we lock down our schools. And we only have 16 minutes left, so just keep that in mind.
Okay, so thanks, Mark. So what do we know about COVID-19 in children? What we do know about COVID-19 in children is that children don't develop a severe illness. They rarely develop a severe illness. In fact, right now, as an example, in Italy again, right, 30,000 deaths from COVID-19, right, of which none occurred in children under the age of 18. In the United States, at a time when there were 150,000 cases of COVID-19, less than 2% of those cases occurred in children. There were only 3 deaths in children, and all 3 deaths occurred in children that had underlying medical conditions. So for some reason, for the first time that I've come across in 25 years of studying respiratory pathogens, children are being spared severe disease from COVID, from a respiratory virus, in this instance, SARS coronavirus 2. We don't fully understand the reason for that. It might be because they sort of exposed to many other coronaviruses that circulate in the community. There might be some cross-protection because of that sort of exposure. Right, so children do not develop severe disease from SARS coronavirus 2. I shouldn't say they do not. They rarely develop severe disease. And when they do develop severe disease, they're more likely to have an underlying medical condition. There's only a handful of children that has died from COVID-19. Despite there being over 250,000 deaths from COVID-19 now, a handful of children have died from it. Right? And this is experience in the United States. This is experience in Italy. Now, the other concern was that children might be an important vector in terms of transmission. And that concern wasn't based on any data related to SARS coronavirus 2, but rather it was an extrapolation from our experience with influenza, with seasonal influenza, where we know that school-age going children are important vectors in terms of transmission within the household as well as in the community. We know that we experience that every year. It's not unique to South Africa. Now, that was one of the main reasons why people were saying do not close the schools, right? Because children are a possible vector of transmission. Now, more recently, there's different pieces of information that have come together, including a study from the Netherlands, which basically looked at who were the infectors and who were being infected, right? And what they basically showed is that there's sort of a linear relationship between people that are infecting each other. Adults are more likely to be infecting adults, and adults of the same age group are more likely to be infecting adults of the same age group, right? Because they're obviously in the same sort of social circles, right? Adults are the ones that are infecting children. there's been hardly any documentation of children being responsible for infecting adults in the Netherlands. In an outbreak investigation in Australia before when they went into lockdown, they investigated about 780 contacts of 18 individuals that were infected in the schools. 9 were children, 9 were teachers. Out of the 780 contacts, close contacts, there was only one case that was identified to be a secondary infection. And it's unclear whether that person was actually infected by another child, a teacher, or whether that infection actually occurred outside of the school. Okay, and so the entire reason why children are not developing severe infection, it's not just by chance. It's about the immune system, right? So the concern is, do children have the same sort of viral load? So by viral load, I mean the amount of virus you got at the back of your throat, which is what makes a person infectious. Right? By virtue of them not developing severe disease, it suggests that when they've got a mild illness, when they're asymptomatic, they probably got a lower viral load than in adults. Right? But the number of children that have been infected is so few that we can't actually do a reasonable investigation of it. But what we can say now from the experience, and I'm not the only one saying this, there was an article in one of the pediatric journals just on Friday, which says exactly the same thing, that it's time to open schools. Children are being punished. They're being punished, right, for a problem which they're not actually at risk of developing severe disease. They are not the vectors of transmission for SARS coronavirus 2, right? So we need to rethink, right, the paradigm that we operated under in terms of why we closed schools in the first instance. This is not seasonal coronavirus. The transmission dynamics is not the same when it comes to children as being the vectors, right? In fact, if anything, children are spared severe disease from SARS coronavirus 2. So we are not protecting children by not sending them to school.
So you cite all of these studies, and they're important studies, but you as a scientist know that science remains inconclusive for quite a long time. Isn't there a danger in jumping the gun? I mean, just in the last 48 hours, we've heard about this cluster in New York, Kawasaki disease or something, in a group of children who all had COVID-19 or COVID-19 antibodies. Don't you think you're jumping the gun a little bit here? And what are you actually saying? Are you saying that we should plan to open the schools from grade R to grade 12, or from grade R to grade, is this a primary affecting younger kids or older kids? Just clarify those a little quickly. We got 10 minutes.
So when I talk of children, I'm talking of children under the age of 18, and that is the experience that I'm citing from Italy, from the USA. We're talking of children as a group under the age of 18. Now, the fact that the article that you mentioned that came out today, Kawasaki's disease, because of COVID-19, there's a temporal association. We're not too sure whether it is because of COVID, right? But the reality is that the fact that it makes the news is that it's so rare that it is making the news. And that's the reason why it's making the news. It's not making the news because it forms a significant percentage of the number of individuals that are actually dying. And the authors of that paper and a commentary on that same paper indicated the same, right? That this might be a finding, but the reality remains that children are spared from developing severe disease as a community. There are going to be exceptions, like in any other field of medicine. There are going to be exceptions. It's never all or none. Are rare cases where few, fortunately, are developing severe disease, right? And then you need to ask yourself, what is the trade-off, right? What is the trade-off? We are talking about close on to 17 million children being operated for 15 million children being in schools, right? What is the trade-off in terms of putting the future of 15 million children on the line, right? And Mark, the other important thing is any decision-making that takes place now, and this is what we need to accept, right? Is that this virus is not going to go away. This is not going to be a single wave epidemic. We're looking at 3 to 4 waves of this epidemic before we get to a vaccine or before we get to herd immunity. This is whatever planning we do now, right, is a planning that needs to be in place for the next 2 years. It's not for the next 3 months. It's not for the next 6 months, right? Because we will be having the same discussion in 3 months from now, right, if we don't plan for the next 2 years. And I think that is a message that needs to sink in. The other message that needs to sink in, irrespective of what we do, right? Roughly 60% of South Africans are going to get infected, right? Irrespective of what we do, right? We're not an island nation such as Iceland or New Zealand where we can actually prevent that from happening, right? So 60% of South Africans are going to get infected during the course of this pandemic. And the reason why that might start waning after that is because that's sort of a critical threshold that's required before you're likely to develop what we call herd immunity, where the virus, the effective reproductive rate, where one person is less likely to infect at least another person, drops to less than one, right? And that is something that we need to accept. But at the same time, we also need to accept that this is not a doomsday scenario. Of every 1,000 adults over the age of 18, right, 60% of them are going to get infected, which means 400 of them are going to be completely asymptomatic. Of the ones that get infected, right, 70% of them, 50 to 80%, let's say 70%, are going to be asymptomatic. They won't even know that they were infected. 70%. Of the remaining 20%, 25% will actually have a mild self-limiting illness. It's 5% of that 1,000 people, adults, that will require hospitalization, which translates roughly into about 25 to 26 out of 1,000 that will require hospitalization. Of that 1,000, right, 3 to 4 people, unfortunately, might die. 90% of the people that will die, unfortunately, are going to be those older than the age of 65, people with comorbidities. And that's the paradigm we need to look at this. When it comes to children, out of the 1,000 children under the age of 13, 2 children might be admitted to hospital, and 0 children out of the 1,000 will actually die from COVID-19.
Yeah. So you're standing by schools should reopen. That's what I'm hearing.
I think there needs to be there needs to be a much more rapid phasing in of the opening of schools. Necessary precautions need to be taken when it comes to physical distancing between the teacher and the students. Children are going to infect themselves. They're going to infect each other. There's no avoiding it. Right? Whether they get infected in the school or in the community, those infections are going to take place. That's the nature of a respiratory virus. You can't avoid it.
Okay. So again,
the NIG needs to be in place.
So you're not saying, Prof, you're not just saying, you're saying it's essential that we have a plan now to reopen schools done in a responsible, measured, careful way with public health messages, with full prevention, hand sanitizer, masks, everything, but reopen schools. I just don't want anybody to think that you're saying open and be damned.
I'm not saying
that's not
certainly not. And I think the first lesson when everyone goes back to school is educators need to be telling the learners what to do to reduce the rate of transmission. That is the first lesson. Before they do any other lesson in school, that is the first lesson. And in fact, the learners need to be assessed on their knowledge about how to actually reduce the rate of transmission of the virus and why it's important.
Okay, so Prof, we're down to, unfortunately, about 5 minutes left, which is a great pity because these issues are complex and we're scratching the surface. But I've heard you offering a different perspective on lockdown, on testing, on messaging, on how we ensure that a collateral damage is not done to other health interventions, be it TB. You mentioned to me before we even came online that Chris Hani Baragwanath has had to admit some children with severe acute malnutrition for the first time in years. So there's trade-offs going on, but you've presented a different perspective. In 3 minutes, is anybody listening to you? And are you just Professor Mahdi, the Maverick, on your own raising these questions, or are there other people in the medical community who share your concerns or similar concerns? And how do we get you heard? How do you get heard?
So Mark, I might be moving in the wrong circles, because in my circles, everyone actually sings from the same hymn page. We all on the same sort of level in terms of what needs to be done. And that's the reason Mark Mendelsohn co-authored the article. He was the first author on that article that you referred to when it comes to testing. These issues are being discussed in the hospitals, right? And to be honest with you, I haven't come across someone that has told me that I'm talking nonsense. And what I'm saying is not my opinions, right? And I think we need to be clear about it, right? These are discussions I've had with other people and discussions other people have had with me that have come to this sort of position. And it's not a Shabir Madhi position. Let's be clear. This is not a Shabir. I'm not any unique person. And I would hate to be called an expert on COVID-19 because there aren't any experts in the world on COVID-19, or else we wouldn't be in this mess, right? And that is the reality. So these are not even opinions. These are based on scientific. What I'm describing is not based on opinion. I'm basing my messaging on scientific evidence. Right? When it comes to schools, when it comes to children, it is not me thumb sucking in terms of children not being a risk group for severe disease. That is the scientific evidence from the rest of the world.
Thank you very much, Professor Madhi. You're a member of the Ministerial Advisory Committee. I think you chair one of its subcommittees. Do these issues get discussed at the Ministerial Advisory Committee?
Yeah, so the Ministerial Advisory Committee has got a very specific mandate, and that is to sort of go over issues which the Department of Health refers to it to basically deliberate on and to provide an opinion. So it's got a specific mandate that it's only there to basically provide advice for issues which are actually tabled to it for discussion.
Okay, thank you. So look, let's wrap up. Just before we wrap up, interesting, we ran a poll during this conversation asking people whether they felt that the lockdown should be ended now. We did the same poll in fact, just before the lockdown started with Professor Abdul Karim, when I spoke to Professor Abdul Karim. And at that point, about 85% of people supported the lockdown. The poll that we've run this evening, 77% of people say end lockdown now, and 23% say don't end. That's interesting, but it's a crude measure, because our discussion this evening hasn't been to lock down or not to lock down. It's been about the multiple layers of interventions that are needed if our country is to be effective in controlling COVID-19 and to minimize the number of deaths. That's our overall objective. It's difficult to have a conversation like this in such a short time. I mean, I've seen people say here, you talk about social distancing, but there's 50 kids in a classroom in South Africa, which I know from my own work is true, that there's no water in many schools. So the challenge is, how do we make the science fit the reality of our schools, of our workplaces, of our clinics, and of our other facilities? Is there anything you would like to say just in parting, Professor Madhi? Literally, you'll have to confine it to 30 seconds, but this has been very, very helpful. But any parting suggestions to people who've been with us? 1,700 or so people been with us for the last hour.
Yeah, Mark, look at the bottom line is that it's collective responsibility that's going to win this, not win the war, because we're not going to win a battle against this virus, but it's us taking on collective responsibility in terms of ensuring that we reduce the rate of transmission of this virus. So our healthcare facilities are better equipped to deal with the surge of cases that is going to come its way, right? But at the end of the day, we also need to guard against the collateral damage that is being done in terms of our response to COVID-19. We need to be broader thinking in terms of the additional number of people that are going to die from preventable diseases. Children are not being vaccinated. They're not getting the basic life-saving vaccines, right? People are not being diagnosed for tuberculosis, right? You heard about malnutrition in the hospitals, right? So we need to think beyond, way beyond just COVID issues that we face, and what are the negative consequences that are emerging because of the response that we've got. And we are not going to eliminate this virus. This virus is going to be with us for another 2 years, right? And our strategy needs to be geared towards what to do over the next 2 years.
Thank you very much, Professor Madhi. We appreciate your effort as a scientist and the effort of all our other scientists and our healthcare workers in this country. We appreciate the efforts of our government and of our president and of our Minister of Health. This is unknown territory that all of us are in, but you've brought an important scientific perspective to this discussion, and I think people are very grateful. So I'm going to switch off. I just need to thank the Konrad Adenauer Stiftung Foundation, who have made this webinar possible, the people from the Daily Maverick Insider, and everybody who on a Sunday evening has joined us, not out of academic interest, I don't think, but out of an interest in what they can do best and to get the information they need if all of us are to join together in this battle against COVID-19 and to save lives. So thank you for your time and best wishes. And I'm sure you won't get into any trouble for what you've said, because science is science, and we're a democracy, and we're all in this boat together. So thank you, and good night, everybody. Thank you.
Okay, thanks, Mark.